Thanks everyone for joining us today. I'm Tina Robinson. I'm the Manager of Communications and Community Relations with BC Transplant. This is the first in BC Transplant's Fall Speaker Series, and our topic is exploring the ethical considerations of direct contact in pediatric organ transplantation. I recognize there are actually people joining from all across Canada and BC and other First Nations lands across the country. I'd just like to acknowledge, though, that we're hosting this presentation on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Just a few things before we get started and handing it over to the panelists. The webinar is being recorded and we will make it available later through BC Transplant's website and our YouTube page. We'll send an email out to all participants afterwards with a link. You've joined the presentation by default with your audio and your video muted. There is going to be time for questions at the end of the presentations, at which time you'll be able to submit your questions. And there's two ways that you can do that. You can either raise your hand and we'll unmute you to be able to ask your question, or you can type it into the Q&A pane found in the Zoom toolbar at the bottom of the meeting window. Hopefully you all can see that. I have turned the chat function off. That just helps us monitor your questions more effectively through the Q&A pane, just so we have fewer things to have to check for questions. So please stick your questions into the Q&A pane. And if you have any issues, you can email Heidi Butler, heidi.butler@bct.phsa.ca. I am going to turn it over to our three speakers now. Jordy Hermiston, BC Transplant's Program Facilitator for Family Services. Alice Varani, the Director of Clinical Ethics Services with Provincial Health Services Authority, and Jordan Wadden, a bioethicist and the project lead for the research study that you are about to hear about. I'll turn it over to you now. I'll stop my share and hand it over to you. Thanks.
Okay, so our screen should be shared now. Please, someone let us know if it is not. As was said in the introduction, our project is titled Exploring the Ethical Considerations of Direct Contact in Pediatric Organ Transplantation. This was a qualitative study. So the research team consists of the three of us, as well as three others. We had Tom Blight-Hansen from the Multi-Organ Transplant Program at BC Children's. We had Ranjit Dhaliwal, who is a patient and family partner. And we had Shelby Geelan, who is also a patient and family partner. We have included our own land acknowledgement, again, just because myself, I am joining from Ontario. So I'm on the lands of the Mississaugas of Scugog Island First Nation under the Williams trees. But you or others who are watching this, as well as our participants, who we interviewed some as far as Quebec after they had moved from being in BC, might find yourselves on other lands. So it would be good to take just a moment to recognize the lands that you yourself are on. Additionally, before we get started, we had some funding for this project and we could not have accomplished it without the help of the Transplant Research Foundation of BC. So our research was funded by a 2021 TRF BC venture grant. We have structured the talk, oh, I think my slides are frozen. While I work on that, we have structured the talk in 4 different sections. We have a background, we have where we're talking about why we were asking this question, why we thought that this would be a good project to move forward, how we set up that project. We then also have a section on our methods so that you can understand what went into our study and how we decided to move forward with it. Then we'll be discussing our results as well as the discussion that comes from those results, where we started to look at the ethical and policy implications. I have to stop sharing my screen for a moment just because I cannot get this to unfreeze. I apologize for this. Okay, I've got it back, just 1 second. Okay, so outline for the talk, and I will pass it over to Jordy to talk about direct contact with adults.
Great, yeah, so the background for the study kind of came out of us at BC Transplant establishing policy and a practice framework for supporting direct contact between donor families and adult transplant recipients. This has come out of kind of a long tradition of anonymous correspondence being well established between donor families and transplant recipients across many ODOs around North America and the world. So we started a direct contact program, which was formally launched in November of 2019. Direct contact in this situation, meaning it's an interaction between a donor family and a transplant recipient that isn't anonymous. That can be independently, or that can be independent or facilitated by a member of a healthcare team, like myself at BC Transplant, for example. And it can include the exchange of names, personal email addresses, mailing addresses, telephone numbers, and it can also include in-person meetings. So this was largely created in response to self-advocacy from donor families and transplant recipients. This population was clearly saying to us as an organization that kind of the longstanding practice of absolute anonymity was no longer meeting everyone's needs. So you can go for the slide. So we established through focus groups and kind of literature reviews and environmental scans of other ODOs, 3 criteria to be able to be eligible for direct contact in the adult program. So first, the donor family and the transplant recipient must have exchanged anonymous correspondence back and forth at least once. A minimum of 12 months has passed since the date of donation and transplant, and BC Transplant must have received an initial independent request for direct contact from both the donor family and the recipient. This criteria was really important because in focus groups, we heard from donor families and transplant recipients for whom absolute anonymity continued to be important. And we also heard from folks that really wanted that opportunity for direct contact. We felt that to meet everyone's needs, we had to create a system that was independent, and the risk of kind of agreeing to something that you maybe weren't ready for to appease the other side was accounted for, essentially. So when there's a match, all these criteria match, a social worker, which is myself right now at BC Transplant, will support the donor family and the transplant recipient through a consent process, which includes meetings and discussions independently about expectations, hopes, fears, talking about boundaries and who that person's support system are, what strengths are they bringing to this new relationship. And then I work with both sides to kind of co-create a plan for direct contact that meets everyone's needs and feels comfortable for everyone. Some people might be really gung-ho about meeting in person right away, while others might feel that, you know, exchanging personal email addresses first and allowing that relationship to grow in a more organic way is a preferable first step. So we try to meet everyone where they're at. And then we, once the consent process is completed, we've received consent forms signed by all parties. We do a release of the specified identifying information between the donor family and the transplant recipient. Go ahead. So that sometimes that could result in an in-person meeting facilitated by myself. Sometimes that could result in just personal emails being exchanged, as I said. I did a quick scan of kind of where things are at with our anonymous correspondence and found that in 2021, so for all donors and donor families and recipients in 2021 in BC, about 41% have received or sent anonymous correspondence as of last week. In 2020, that's about 56% of those folks, and 2019 about 51%. So, I mean, this isn't rigorous by any means, but it gives you a snapshot of about like roughly how many folks are at baseline reaching out to try to connect. And then to date, BC Transplant, we've supported about 12 donor family and transplant recipient pairs through the direct contact process. Some of these have included in-person meetings, some haven't. And then there's about 23 donor family and transplant recipients who've, on one side, taken that step to independently request direct contact, but haven't matched yet with a request from the other side. And go ahead.
Thanks so much. So this is kind of shifting into some of the ethics of the discussion, which I think, just listening to Jordan so far, you've heard a little bit about what they might be. So, we have a program in the adult setting where, a lot of the work that Jordy does at BC Transplant is to in setting up these matches and having these direct contacts is around really respecting people's voice, respecting people where they're at, respecting their ability to make informed choices for themselves, respecting their ability to meet in a way that suits them best, etc. But what do we do in the pediatric setting when we have kids and we have adolescents and they're not fully able necessarily to provide an informed choice because there's questions around their capacity. They either are way too young to have the capacity to make a decision, or they're in that kind of developing capacity stage of adolescence where they're gaining the ability to make complex decisions, but still need support in that. So it's a really interesting one from an ethics standpoint. And I think part of the thing that we wanted to do when we were looking at this was say, okay, well, we have this question, and how do we make informed policy around this? And when Jordy talked about some of those numbers that you see around, like how many people are actually opting for this, 50-ish% are saying they want it, and 50-ish% are saying they don't want it. So we can't easily say, oh, this is something that everyone wants, so we should, promote it in a pediatric setting because, we have a good sense that that's what kids would want to do because that's what most adults would want to do. And we can't say, oh, no one wants this, so we shouldn't do it in a pediatric setting. So we don't have a really good sense based on those kind of numbers. So how do we get information so that we can make a good evidence based decision as much as possible? So the key questions really that bubbled up for Jordan and I when we were talking about this and talking with our patient partners and talking with Jordy and Tom were around, okay, well, we have children and adolescents, and we shouldn't just be making blanket choices for them. It would be really great to have them involved in some of this decision making. What do they think? What do they want? And how can we promote their capacity in developing autonomy by involving them in the research around this? So that's one of the things we wanted to look at. For those of you who don't do a lot of work in pediatrics, you probably are aware of this, but in a pediatric context, if we have an adolescent or a child who doesn't have the capacity to make an informed decision and doesn't have the ability to make an informed choice, we usually look to their substitute decision makers. However, this is complex, right? Should substitute decision makers make this decision for them? Usually in healthcare, we kind of say, okay, well, if there is a time limited decision, like a kid has cancer and we need to start cancer treatment right away, and the kid doesn't have capacity, we look to their substitute decision makers. We can't wait for them to get old enough so that they have capacity. But what about here? What about this situation? Can we wait until kids and adolescents have the capacity to make decisions? What are the risks and benefits of waiting? Maybe the ability to make that connection might not be available many years down the line. So those are the kinds of things which come up. I think I touched on these, but children and adolescents, there are additional ethical considerations there. We recognize that there is an elevated vulnerability there's a bigger impact of family dynamics and you know, influenced by family members who might have strong opinions one way or another, and kids are always in that power hierarchy with the adults around them, be they, you know, adults within the home or adults within the healthcare system. And there's also legal considerations. The age of majority in BC is 19, and we have the Infants Act, which gives some guidance. But you know, there's other questions that come up as well, questions around privacy, etc. We also recognize that, you know, we have to balance some of these risks with some of the benefits. You know, we might be empowering choice, and particularly in my interactions with some of the transplant patients that, you know, I've worked with at Children's Hospital, I've heard, you know, many times that, you know, one of the things which has been really challenging for them is they have felt disempowered in their healthcare journey. They've not felt like they've had a choice as to what's happened to them, and healthcare has just happened to them. And so how can this question and discussion be perhaps an empowering moment for them, which really respects their choices, them as an individual, etc. And we do know that we want to avoid paternalism. Yes, we have that duty to protect from harm, but we also have to be mindful of that paternalism piece. So next slide. We looked at the literature. Well, Jordan did a really good job of looking at the literature, and I looked at the literature that he looked at. But nothing in the literature really directly discusses this topic for children and adolescents. And you know, when it is discussed, it's really just a brief subsection or a mention. There was some media. There are some media articles out about this. I think there was a Wall Street Journal or something article about this, and there's an organization in the US called transplantfamilies.org that believes in this type of direct contact between children and donor families, because it, you know, it addresses concerns of isolation and possession, but it's really not well understood. And so that was really kind of why we want to conduct this research, to kind of say, well, if we are going to look at, you know, developing some guidelines and policy around this, how can we make sure it's as evidence-based and as based in the literature as possible? And when we don't have much literature, then we have to create our own evidence. So this was really it. Like, the goal was to examine the ethical landscape of direct contact for children and adolescents, to determine if such a program could be extended or should be extended to this group of patients by hearing directly from those affected. So I will hand over now to Jordan.
Sure. So part of what we did find in the literature, again, the literature is only expressly talking about adults, is that donor families often feel uninvolved or unsupported following a donation, which can be especially difficult when they feel that there might be a bond between them and the recipient or the recipient's family. And this comes up quite a few times in the literature, as well as a few other oddities that we might not initially think of when we're thinking transplant and donation. The recipient side, they also have some experiences that are unmet unless there is some sort of option for direct contact. So for the recipients, they can experience psychological or physical distress by the process of transplant, which we understand for a good amount, but these can also include conflicting guilt and gratitude, and feelings of incorporation, because they are now incorporating another individual into themselves. For some recipients, that's how they end up feeling. And the conflict between guilt and gratitude is kind of best described as seen in the literature as, why did I survive? But also, oh my God, I survived. Now, despite this, there are some organizations that have felt the burden to enforce anonymity due to the risks of harm, especially when there's a perceived imbalance in the relationship. And one of the biggest cited imbalances is the idea that the recipient can never really fully pay back, if we're using that kind of relationship model, they can never really pay back what the donor family has given to them. You can't really pay back for a life that has been lost to provide you with life. So that's part of the reason for a desire for contact is to at least get a semblance of that relationship, get a semblance of the incorporation dealt with, get a semblance of support. So we wanted to see if that was going to be the same for the pediatric and adolescent side as well. We led our study based off of 4 main questions, and these were heavily influenced by both the literature, but also by the patient and family partners that we incorporated into this study. So our first question was, what are the harms and benefits of allowing or preventing direct contact program in the pediatric population? We wanted to see this so that we could accurately have a recommendation towards whether or not this should be permissible. Not whether or not something should be created, that's for the other questions, but whether or not there was actually an adequate balance of those risks and benefits that Alice was discussing a few seconds ago. Our next question was, is it appropriate to have parents acting as substitute decision makers? Again, because as Alice was saying, when a child isn't able to consent, we do turn to their SDMs, which is generally their parents or their guardians. So is this the kind of program that if it was created, we should actually have that kind of relationship when it comes to consent? Or should the child always have to be the one consenting? Or should it be withheld until a later date such that the child can consent? Those are the kinds of things that we were looking at with this question. We also wanted to check to see if restricting direct contact to the adult program was an issue of fairness, was an issue of justice. Are we unduly preventing a group of individuals from accessing a service when they should actually be allowed to, just as any other who has that access? And then finally, if all of these questions pointed towards creating a program, we wanted to also know what supports need to be in place for those who go through the program and who want to participate in that direct contact. So moving into our methods, potential participants were identified through internal patient records at BC Children's as well as BC Transplant. We had Jordy and Tom working on identifying those individuals. And these participants were recruited based on 3 broad categories. There were recipients who had received a transplant as a child or an adolescent, but are now followed by the adult program, as well as their families. Recipients who received a transplant as a child and are still in the pediatric program, as well as family members of deceased organ donors. We chose these 3 groups because we wanted to make sure that we had the broadest possible understanding of our questions. So we looked at the family members of deceased organ donors because we wanted to make sure that this wasn't just a program for recipients if we decided to recommend it. We looked at recipients who are in the pediatric program now because those are the ones who would be most affected by this. But we also looked at those who have graduated into the adult program because we wanted to see if thoughts and opinions changed as they aged. And we used that, we did the adults first so that we could tailor our questions or come up with new questions that we might want to ask the current adolescents, just to make sure that we were doing this as safely and respectfully as possible. Again, recognizing that the ones who are still in the pediatric program are much closer to their transplant date than the ones who have graduated out and are in the adult program now. We did this through semi-structured narrative-based interviews during the spring and summer of 2021. These interviews were held on Zoom for a myriad of reasons, not the least of which being that it was the height of COVID pandemic. If you can say that there's a height, we don't know going forward. But also because these are individuals who are across BC, and some of the donor families aren't even in BC anymore. And for the recipients, at least, these are people who still have some vulnerabilities, especially around infection. So we wanted to make sure that we were keeping this as safe as possible while still keeping it as open as possible for participation. These interviews ranged 27 to 83 minutes. Really, because this was only semi-structured, we had guiding questions, but we wanted to have a more organic conversation. I'll show the interview guide on the next slide. We just wanted to make sure that all of these topics were touched on instead of going question by question by question, because that might feel more like we were extracting information rather than trying to really dive into their feelings, their views, and their desires towards this kind of a program. We took a naive and collaborative perspective on this to encourage that it was participant-centered. I see the P word every time. Participant-centered knowledge translation. That way we weren't affecting any of the knowledge that was coming our way by saying that, oh, we're experts in the medical field, so here are the things that must matter. We're not experts in the transplant lived experience field. So we took this from a naive perspective to make sure that we weren't making any sort of assumptions about what mattered and what people actually wanted to talk about. And for our coding as a qualitative study, we used a combination of deductive and inductive codes in our analysis. The deductive codes were taken from the interview guide so that we had one for each of our main questions, but then we also used inductive to allow codes to emerge from the conversations that we had, to allow important things that we might not have thought about to actually become important things in our analysis. So very quickly, here is our interview guide, heavily influenced by the input of our patient and family partners, Ranjit and Shelby. Some of these questions came directly from them as individuals with this lived experience. Again, myself, Alice, Tom, Jordy don't necessarily have the experience that they did, and we really relied on them. We separated it into three broad categories, being context development. So what's the journey been like as a recipient or as the family of a donor? What kind of emotions did you feel? Just kind of setting the scene to talk about this conversation. We then looked at details and opinions, which is whether or not they have wondered about the recipient if they're a donor family, or the donor family if they're a recipient. Would they want to meet? Would it help the recovery? Do they think that there are any harms? What are the thoughts on the consent piece that we were asking about? Should parents be able to consent on behalf of their children for this? And is there any reason that it should or should not be expanded to adolescents? And then finally, we ended with community needs. So this includes what supports were needed if this was to go through. What would be an appropriate timeline? Should it be a year just like for the adults? Should it be longer? Should it be shorter? Those kinds of considerations. And then we wanted to know, was there anything about the experience of being a recipient or donor family member that just doesn't get talked about and isn't recognized, that they wanted to say and express, that maybe could either impact this study or impact future studies? We had 29 participants across 20 in-depth interviews. Some of these included both family members and the children, or family members and the graduated adult. That's why there's less interviews than participants. We had 18 women and girls, 11 men and boys. We ended up losing a few participants to contact, or those who directly declined, thinking that we had reached out to them in error, as some of the donor families had expressed. For pediatric recipients who are now in the adult program, we had 13. Recipients currently in the pediatric program, we had 11. And family members of deceased donors, we had 5. Breaking that down again into the organ categories, we ended up looking at 3 major categories. So we had 3 adult and 6 adolescent kidney recipients. We had 4 adult and 2 adolescent heart recipients. And we had 3 adult and 6 adolescent liver recipients. So I'm going to move into the results. And for the majority of this, I want the participants to be able to speak for themselves. So on the slides, I've included quotations. For our participants, we had them choose their own pseudonyms so that they could be kept anonymous, but also still be represented, still have some sort of personal connection to their information that they shared. So you'll see names, know that those are pseudonyms, those are not actual participant names. So for the question of transplant, donation, and just becoming a member of this community, virtually all who could remember, as well as the parents of those who could not, reported that the process of becoming a transplant family marked them with an increased sense of either responsibility, worry, or more protectionist thinking. All reported, however, that becoming a transplant recipient or family gave them an overwhelming sense of gratitude. Now, of the donor families who participated, all expressed that becoming a donor family was meaningful to them and their loved ones. These participants frequently used words like silver lining to describe the experience of becoming a donor family. All of them again expressed that donation was unquestionably aligned with their loved ones' values. Now, all families, both recipients and the donors, expressed experiencing difficult emotions during this journey in one way or another at some point or another. Frequently used words included impacted me for the rest of my life, or roller coaster, draining, cried a lot, and shock. Several individuals from both groups also stated that the feelings and emotions associated with becoming a transplant recipient or donor family were just inexpressible. They could not put them into words. Now, when we started to look at the sense of wonder, so what are you connecting with? What do you want to know more of? 19 participants explained that they wondered about their donor, their donor's family, or their loved one's organ recipient, while 7 expressed that they never really wondered, and 3 didn't answer the question as phrased. Of those who did wonder, 16 were recipients and their families, while 3 were donor families. Common questions included how old the person was, what their health was like prior to transplant or donation, what it was like after transplant if they were a recipient, and it was the donor family questioning. Most frequently, though, the main question was whether the other individual knew how much donation was appreciated on the recipient side, or whether the other individual's life had improved on the donor family side. 15 of our participants expressed wanting the program to exist for themselves, while 4 participants said that they wanted the program to exist. This is a direct contact for adolescents, but they would not themselves choose it, these 4. And then 6 expressed no interest in such a program one way or another. 11 had, this was very interesting. This was actually one that caused us to pause for a little bit and figure out how we wanted to move forward with our analysis after we had our data. 11 of our recipient participants had either met their donor family, 5 of them, or had learned significant personal identifying information, 6 of them. These families expressed dissatisfaction with the medical system's current limitations on figuring out this information and lack of supports. They explained that they understood most clinicians were just looking out for their safety, but they also explained that this was something they felt they had to do and something that regardless of supports, they would have done if they were given the chance again. So that brings us into our question about harms and benefits. Beginning with the harms, only 5 participants expressed that they thought contact might result in some personal discomfort or more significant harm. 4 expressed that they were unsure or they were adults now and they were just too removed from the situation. And 13 expressed quite explicitly that they saw no potential for harm. Harms that were referenced by the participants who said that they did feel there might be harms included being emotionally overwhelmed, having different backgrounds or core beliefs than the recipient or than the donor family, or that the other family's trauma might bleed into their own trauma and potentially re-traumatize, potentially make current traumas worse. But now surprisingly, despite only being asked about personal harms, 14 participants expressed that they were more worried about potentially harming the other person, so the recipient if they were the donor family, or the donor family if they were the recipient. And that this was more important to them than their own potential harms. Regarding benefits, 23 participants indicated they believed direct contact would have helped their recovery or their grieving process, including all 4 donor families who responded to this question. Some of the benefits referenced included being able to get closure, being able to express gratitude, being able to contextualize their own experience, and just knowing that their loved one's gift was well received. Again, despite only being asked about benefits to themselves, 20 participants, including all 4 donor families, expressed beliefs that this could be more beneficial for the family that they were connected to rather than themselves. Several expressed that while they might personally benefit, the main reason they wanted to have direct contact was instead to provide benefit to someone else. Now, looking at policy considerations, this is the one slide where I don't have family quotes, as it was a little bit difficult and there were some, this was where we found the most conflict between the participants. So questions regarding policy really elicited two main tensions, which is whether it would be appropriate for the parent to consent to direct contact for the child or adolescent, but also at what age a youth could make the decision for themselves. So among parents of recipients, there was no clear consensus about whether parents should consent, adolescents should consent, or whether they could even decide who was the most appropriate at the time. Among recipients, half of them felt that they should have the sole ability to consent for direct contact, and of the remaining 6, most felt that it should be a family decision. From the donor family perspective, only 3 of the participants responded to this question, and unfortunately this means that there were just too few responses for us to be satisfied we had saturation. So this would be something that needs to be investigated a little further regarding the policy and the consenting side. Now, regarding the appropriate age to begin consent, this one was, the recipients were distinctly split between the parents and the children. And this includes the children who are now in the adult program. So they are in their 20s or even older. So the responses from parents tended to claim that the child would have been or currently would be able to consent without their help as a teenager. Of those who gave ages, they said something between 14 and 16. Now, among recipients, again, both graduated recipients and current recipients, they thought that it should be much earlier. Those who gave explicit numbers said that it should be between the ages of 9 and 12. Now, importantly, on both counts, graduated recipients and current adolescents appear to share the same views on consent. So there seems to be some sort of through piece, some continuity in that thinking, even after the recipient has become an adult themselves. Finally, from our results, we wanted to focus on what the community needs. So 3 of the most commonly requested supports were psychologists or counselors before the meeting, social workers before and after the meeting, and mediators during the meeting, this meeting being the direct contact meeting. Other supports included family meetings, mentorship from those who had already gone through with direct contact, information packages, potentially financial aid if there was travel involved, and clinician involvement in the meeting, a few of them indicated. Additionally, recipient families strongly believe that any support they could access should also be available to the donor families. They were uncomfortable with the idea that potentially they could get resources, but the donor families might not. They wanted to make sure that it was known in our results, multiple families wanted to make sure that it was known in our results that donor families should also get that same treatment. Almost all participants who responded to this set of questions indicated that families should be told about direct contact in the general information packets before transplant, as part of information discussions immediately after transplant, and sometime shortly after during a follow-up. So they wanted to have the information more than once. And regarding the interval of time to wait before a meeting, this was another one that had quite a large range. It would need more investigation. As some said immediately, they wanted to meet while they were still in the hospital. And others were saying, no, we like the idea of 1 year or more. So there's really no front runner there. Accompanying this, however, was the frequent clarification, but it depends on individual recovery. Finally, participants were asked what they wished more people knew about being involved in the transplant program. And while many thoughts emerged from this question, some common items included remembering that transplant recipients are just like any other person, that transplants are not cures, that being a donor can give your family a sense of peace and purpose when your loved one passes, and that transplant research really needs to focus more on the recipients and donors' lived experiences, and that some of our participants felt researchers in general have failed to create enough pediatric-focused studies. So we're going to go to the discussion, and I want to make sure that we have time for questions, so I'll make sure that this is quick. The first thing is just, what does this all mean? It means that there seems to be a distinct desire among the transplant communities for direct contact programs for pediatrics and adolescents. So while clinicians, ethicists, policymakers might worry about the harms outweighing the benefits, the opposite might be true. Again, we'd need to look into that a little further. We had several pre-study discussions with clinicians who indicated that they thought the harms outweighed the benefits, that participants then indicated the opposite was true. In the literature, there also seems to be a lot of worry around harms outweighing the benefits. So going back to what Alice was saying about making sure that we're not being paternalistic, this might be something to give us pause in our current policies around who knows what's best for the individuals. Recipients and donor families also listed potential benefits for the other groups that were consistent with what the groups assumed their own benefits would be. So recipients thought donor families could benefit from having closure, and independently, donor families felt that getting closure was the biggest thing they stood to gain. Recipients' families, the donor families, they all tend to know more than we think they do. And this is about their health, their situation, but also about who each other are. There's a lot of stories out there about people who have read the newspaper, read obituaries, and been able to think that they found contact with the person that is related to them through the transplant process. And one of the things that the recipients and donors said during our conversations was that having some sort of supports might help us with this. Having some sort of supports might make this safer, but we're going to do this anyway. We're still going to move forward with this. We also know that direct contact needs to be consent-driven, and it must center on the pediatric recipient. Parents and guardians can assist their child, but they shouldn't really have the final say. This comes less from the direct quotations, but more from the quotations plus the ethics analysis that we conducted afterwards. And this is because it's not necessarily a medical procedure where we would need to contact the parents. It's not necessarily a time-sensitive procedure, but in a way it is also somewhat medical, and in a way it is also somewhat time-sensitive. So to balance all of the potential harms and potential benefits, it should focus on the kid with strong interaction with the parents and guardians as well. But the parents shouldn't be the ones to say yes or say no, because the benefit isn't necessarily to them, it's to the recipient and to the donor family. And then a final piece before we get into the questions is for that very reason of consent, and also for the reason of those individuals who are going to look for each other anyway, this creation of a direct contact program for adolescents and pediatrics could be built from a harm reduction lens. Harm reduction, it's normally thought of in illicit substances, but the main principles behind it is that we know something is going to happen, so how do we reduce and mitigate the harms, knowing that we can't fully remove the harms by preventing the action from happening? Looking at it from a harm reduction lens, having a direct contact program for adolescents and pediatric recipients, as well as the donor families connected to them, could ensure that those who want to have contact receive integrated supports and a controlled release of accurate information, rather than doing sleuthing online and potentially harming themselves, harming each other, or connecting with the wrong person and developing this potentially fake narrative accidentally. Many who have knowledge of their recipient or of the donor family indicated they were going to continue this anyway, and that support would be beneficial, but institutional red tape is not a barrier. With that, here's a quick view of our references for those of you who will have access to this video afterwards and can pause, but I will stop sharing my screen so that we can get on to the questions.
Okay, everyone, just a reminder that you can pop your questions into the Q&A window, or you can raise your hand and we will unmute you to ask your question live. We do have a question. I think Jordy and Alice, you can see the question and answer pane, so you can go ahead and start answering those.
From Elaine. Hi, Elaine. So that is an important question. So right now, basically in response to what we've found through this study, the next step, now that we have kind of evidence to support our path forward, BC Transplant, in collaboration with the multi-organ transplant clinic at BC Children's, will be creating a working group to figure out how to, I guess, translate the framework and policy that we use in the adult side for the pediatric program, talking about what maybe needs to be added to make sure that we can create a process and a framework that actually supports people to go down this route.
We've got a question from Elaine. Elaine,
Sorry.
I unmuted you. Yeah, go ahead.
I thought it would be easier just to, rather than typing, just ask follow-up questions. So again, thanks so much for doing this really important research. I mean, I do think there's a bit of irony there when you talk about not being paternalistic, yet you need to conduct research to make sure that you're not being paternalistic. I mean, I found that whole concept to be very ironic. But if this is what we need to move forward, then this is what has to be done. So I'm curious now, so aside from the actual program changes or updates, what about publication of the study? Are you publishing the study, and when is that happening? And then will you be sharing the results with all of the participants?
Yeah, so we are currently in the process of having this study reviewed. It's been submitted to a journal already. We have been trying to disseminate this as widely as possible at various conferences, at speaker series, trying to get public events. And once we have the final version from the journal, we are going to be sharing that with the study participants. We want to make sure that if there are any changes that are made to our analysis based off of the reviewers' questions, that those are reflected in the information we give back to the recipients.
And I see a question coming up in the chat saying, what are the implications and consideration of such a policy for interprovincial organ donation and transplantation? It's a great question, and you know, certainly, you know, a lot of the ethics, you know, is something we don't really think about having kind of provincial borders and boundaries, and certainly, you know, the types of ethical values and principles that we would, you know, rely on and think of in our context in our study would apply, you know, across the country and possibly North America, like more generally. There are some slight differences provincially in terms of, you know, whether 18 or 19 is the age of majority, and there might be some differences in consent practices, etc. But really, this study looked at the kind of the ethical implications, and those aren't something we see kind of varying provincially. I'll let Jordy, I don't know if you have a perspective. I'm just curious if it's come up in the adult world.
Yeah, I can add. So it has come up in the adult world. There's only a, I mean, in BC, we have the most interaction with Alberta, and Hope, the ODO in Edmonton, Alberta, also has a direct contact policy and practice framework with consent documents in that. So we have been able to facilitate a direct contact in the adult side between BC and Edmonton. So there's not necessarily, theoretically, there isn't a reason why that couldn't happen in the pediatric side once we kind of establish this policy and practice framework. With other provinces, it's a little bit more difficult because the law, the the law varies a lot more. So for example, Ontario has much more restrictive legislation around transplantation, donation, and publishing or sharing identifying information. So until there's a legislative change in some other areas of the country, that would very much be restricting us across provincial lines. And then I'll just address the other question we have up here. It says, you mentioned that you had some adults that haven't matched, but one party has requested. So do you think that people know to ask? That's a great question. The way that we try to distribute the information about this program widely is if you are participating in anonymous correspondence, which is always the first step to direct contact, that every time an anonymous correspondence is exchanged, we send a leaflet that describes the program, and of course, direct contact being a feature of that program. So I would say that the criteria and the education around the criteria for direct contact is pretty widely distributed if you are someone that's participating in anonymous correspondence. And for the donor family side, which is who I primarily work with in my role, that information about anonymous correspondence and direct contact program is sent out to everyone by letter 6 months following the donation. On the recipient side, recipient transplant clinics have access to those same education materials as well. So we encourage them to be talking to their patient population about anonymous correspondence, and which includes the possibility of direct contact.
We have another question here in the chat or in the Q&A panel. It says, this is an important study. I really like that the donors and recipients knew what they needed. Will more supports be forthcoming, i.e. much like transplant listing workshop, kind of out clearance workshop, not just provincial borders, international, although the number is very small. I'm not sure if that's just a response to a comment earlier, but yeah, asking about supports forthcoming.
I don't know exactly what they mean by like a workshop or what have you. I think that right now how the policy kind of works in BC, that the independent request for direct contact is a really important, I guess, crux point, where that leaves us in a position where we are try to educate as widely as possible that the opportunity is there once you meet these criteria, but like it restricts me, for example, like if I receive a request from a donor family, I can't then call that recipient and say, hey, your donor family is interested in meeting you. Would you want to meet them too? It has to work independently to try to prevent any sort of like undue influence or like any sort of duress in both sides making that decision. Both sides know it's possible if they take the first step and initiate and express their interest.
Do we have any more questions? We don't have any open at the time. So would anyone else like to ask any other questions? If not, then I guess we will maybe just end a few minutes early. We just have 5 minutes left. Thanks very much to our speakers today for sharing the results of their research. It's really interesting for all of us. And thanks to everyone of you who attended from wherever you are across the country. As I just said earlier, we did record the session, so we will be making it available later if you want to watch it again, or if you want to share with others who weren't able to join today. When the session has ended, your computer should actually open up to a new page requesting that you complete a webinar feedback survey. And you'll receive an email tomorrow reminding you of the survey if you don't have time right now to complete it, so you can complete it later. Your feedback's really important to us, just so we can understand what worked well, what we could improve for potential future sessions. And we really do appreciate you taking a moment to complete it. If you would like to register for any other of our speaker sessions, we have another one in a couple of weeks and another one 2 weeks after and after that. So you are welcome to register for those as well. You can do that via our website at transplant.bc.ca/education. And so on behalf of BC Transplant and our presenters, thank you very much for joining us today. Enjoy the rest of your day.